Yeah, I think it's an interesting point. I think both what Dave Boyer and you and Jeff have mentioned, which is start patients with Avastin and switch, and then what Carl and Dave and I do, which is I think the same way. I actually also treat with an on-label therapy from baseline as opposed to Avastin. But in my mind, I use Eylea almost all those patients, those treatment-naive patients, and the reasons I have for that are from an efficacy standpoint. I think it's identical to Lucentis, and in terms of the longevity, in terms of the cost, et cetera, it wins. And so in my mind, if I have to, sort of put my money down on either black or red at the table, I'm going to go right now with treating patient Eylea or Avastin.
Yeah, but I think the only, we're becoming like oncologists, right, where we want to have certain backups, and the only concern I have with, putting all the chips on the table right up front is what happens if that patient then becomes if the patient...
I'm just talking, I'm not all in.
Yeah.
I never go all in.
You're not an all-in kind of person. But I'm just saying that sometimes at least having the Eylea in the backdrop allows you to then, give something to the patient going down the road. So there's always that consideration that having that little backdrop, and it may be that what Jeff is saying is having Avastin as a first line, then you can go to the Lucentis, then you can go to the Eylea as a stepwise approach. We have no data to suggest that either one of those two approaches may be better.
So I'm sorry, go ahead, Dave.
No, but we do have information. Vasada had that one paper that showed that in the Avastin failures, going to Lucentis caused an improvement. But he also had patients in there where Lucentis failures that went to Avastin that had an improvement. So even though the drugs should be that similar, but in a paper that they came out with, they showed this improvement.
Yeah, I do think, though, most of us would say that while we have those few patients who do better with bevacizumab than ranibizumab, it's by far more the other way. And whether there's going to be that same gradient with aflibercept and ranibizumab, right now the numbers who have responded, I've been actually surprised that it's been so consistent an effect. There is one other benefit to aflibercept that we didn't mention, and that's that we've got online labeling that says we can treat every other month and have good outcomes. And while we're still looking at fluid and judging things like that, there are concerns when I have a patient, even when they're doing well on ranibizumab and I start to extend them, it is off-label. And, we're not following the regimen from the studies, and there is data to suggest, at least in 1 year, that you can treat every other month after a loading phase and maintain good vision.
Yeah, but I would say that the thing that's been most surprising to me using aflibercept is the number of patients who need injections every 6 weeks or even 5 weeks as opposed to every 2 months.
Absolutely.
So while it's true that the 2-month data was the approved dose and there was no change in the vision, and that we end up typically at a 5 to 6 week window rather than at a...
And there may be some selection bias there, because there were typically monthly patients on Lucentis that we switched over.
Nope.
But even once you start from the get-go, I think it's 20 to 30% of patients have to be treated more frequently, at least, than every 8 weeks.
No, I agree. And since, I look at that, and I do start, some patients after one treatment if it didn't respond with aflibercept, and I find that many of them can't go out 2 months before they leak.
In the suboptimal responders, I think of those patients as, for lack of a better term, high VEGF need patients. And those are patients who maybe I was treating with double dose monthly of ranibizumab, or some of them, even you brought them in at 2 weeks and they looked great on double dose, and yet 4 they had fluid again, and a few of them we were alternating ranibizumab and Avastin. So I think it stands to expectation that they would require more frequent therapy. In the patients who were treatment naive, it's interesting how we're going to do that, because we know from the VIEW results that most of those patients weren't dry, right? It was roughly about 50% were dry at a year. It stands to reason they were fluctuating throughout, even with monthly therapy, there were, I think it was 73% were dry at 1 year versus 60 on ranibizumab. So there's still a large number of patients that have fluid, even with monthly therapy.
Well,
The only thing that hasn't been said about about both what you start a patient off with. In Lucentis' defense, it's got the most million years of patient use, and it's got the shortest systemic half-life for the little bit of drug that gets in your system, and the least anti-VEGF suppression. It may not matter. In diabetic indications, if it does matter, it probably matters in those patients more. A lot of our AMD patients are diabetic. They've been shown to have decreased VEGF receptors in their myocardium. That's why it gives them silent ischemia. Up to 20 to 25% of patients that are diabetic have silent ischemia. Any little bit of VEGF suppression may further block the development of collaterals. If you worry about any of that, then you would start with Lucentis.
And also, I think the long-term practical use of Lucentis in our clinics, so that we know that patients who've been on Lucentis for 5, 6, or in your case, sometimes even longer, we're not seeing long-term retinal degenerations or really long-term ill effects. We don't have that data with EYLEA, and EYLEA clearly has a higher affinity for VEGF, as well as it has multifactorial growth factors. What is the long-term 3, 4, 5-year effects of that treatment gives me a little room for pause sometimes when I'm thinking about patients, especially if somebody has already existing GA and they come in with choroidal neovascularization. And again, I don't have any data, but it just gives me pause because, as David says, we have this wealth of experience now of almost a decade of Lucentis.
Well, I mean, it's interesting you'd say that. So earlier we talked about GA in anti-VEGF, and you just stated that EYLEA has a higher likelihood of developing GA?
Well, it may. I'm just saying that we have all this practical experience.
It's related to anti-VEGF.
We argued about whether or not there is an
mechanism.
But you're
an
saying,
ill
but
effect.
then you're saying that it's...
I just worried about systemic. I'm just saying systemically, Lucentis is cleared from the circulation in hours. EYLEA and Avastin have days of half-life in the systemic circulation. It's hard for me to believe the little bitty bit that gets in your eye really makes a difference. But if it does, you'd worry more about the ones...
You don't know the EYLEA data.
It's the group that I worry about the most about using Avastin in terms of efficacy is diabetic patients. And those are the ones who I'm more often forced to use Avastin because of insurance issues.
Absolutely.
AMD patients, most of them have primary and secondary insurances, but we're dealing with far more working age patients who have a single insurance. And the copay from a Lucentis, and that's the one that's approved right now, even at 0.3, which is $1,200, the copay is $300 or $400. And if they're getting
The copay assistance programs are phenomenal, though.
if they qualify.
But they're not income-based.
Is that right?
They're not income-based. The copay assistance programs are purely related on your diagnosis. If you've got RVO or DME, you can be a multi-billionaire as long as your insurance is not paid for by a governmental entity. In other words, if it's Blue Cross Blue Shield paid for by the state of Texas,
No pay.
you can't get on it. If you're Blue Cross Blue Shield paid for by the casinos or whatever, you cover.
No pay.
Didn't realize that. Well, that's obviously a big deal because it's the copay that these patients have to experience. So in DME, less so RVO, but DME is a younger patient base in general. In many of those cases, I'm sort of stuck with Avastin.